And we've had some really interesting outcomes from our working groups. Last year in particular, Dr. Jones, who's with us today, chaired a group looking at really how to put that into regular practice in our clinical laboratories and how to work with our clinicians. So what we're talking about is clinical considerations for uncertainty of measurement and traceability. And our first speaker is Dr. Fuentes Ardiru, is the scientific director of the clinical laboratory of the Biltfriguet University Hospital in Barcelona. And he's a member of the Joint Committee for Guides in Metrology of the Bordeaux Institut de Poids et Mesures, and member of the Committee of Nomenclature, Properties, and Units of IUPAC and IFCC. He's also chairman of the Statistics and Metrology section of the Catalan Association for Clinical Laboratory Sciences. Welcome, Dr. Fuentes.
Thank you, Chairman. Good morning, gentles and gentlemen. I believe that metrology is a very important matter in clinical laboratory science. And by the reason, I will try to follow the international vocabulary of metrology in my speech. This international vocabulary has a nickname, the VIM, by this French name, Vocabulaire International de Métrologie. So, the first concept, obviously, is measurement uncertainty or uncertainty of measurement. And this is a statistical definition. It's not very important, this definition. The important thing is that uncertainty is, in most of cases, a standard deviation. This is a basic, very basic concept. And as a standard deviation, we can estimate it by an experiment procedure, and this is the type A evaluation of uncertainty. And one can, in other cases, try to find this from the bibliography and experience and so on, and it's the so-called type B evaluation. In clinical laboratory science, a measurement is made to obtain a measured value that can reasonably be attributed to a quantity. And a measured value is a numerical value and a unit of measurement obtained from a measurement. This is the expression, the typical expression of a clinical laboratory result from IUPAC. And in the first case, this example, 1,5 microcatals per liter is a measured value, not a result. To be a result, to become a result, it is necessary to add the uncertainty of measurement. In this case, in the parentheses, in the second example, this is a really result because there is the measured value 1.5 and the uncertainty. In this case, is an expanded uncertainty. The second concept, very important, is traceability. This is a metrological property, a metrological property of a measurement result. This, when traceability exists, the result can be related to a reference through a documented unbroken chain of calibrations, if each calibration contributing to the measurement uncertainty. It should be noted that a reference, in this case, can be a definition of a measurement unit, a measurement procedure, or a measurement, a reference standard or a measurement standard. And also it should be noted that measurement results are maybe comparable only when have the same traceability. So, two or more measurement values or measurement results become comparable when are traceable to the same unit of measurement, reference material or reference measuring system. The examples in this, the alanine aminotransferase or alanine transaminase measurement of catalytic concentration in plasma is in the 3 cases, or the results are comparable because in all 3 cases they have traceability to the IFCC measurement, reference measurement. But in the other case, because there is a modification in the reference procedure, we cannot say that the result or this measured value is traceable with the others. The important question is why measurement uncertainty is important in clinical practice. There are 2 main reasons for that. It is an indicator of metrological quality. It's a basic indicator of metrological quality. And the second point is it facilitates the exclusion of significant changes independently of any other consideration. In the 2 examples, the laboratory A is poorer than laboratory B because the interval is narrower in the second with respect to the first. This is an indication of quality. All people looking at these results can say that one laboratory is better than the other one under a metrological point of view. In the second case, this example is a patient with this measurement in 2 different moments of his life, or his state in the hospital, etc. We can say that these 2 results are not different. There is no change because there is an overlapping of these 2 values. These are examples of the 2 main reasons for the use of clinical measurement uncertainty in the clinical laboratory. And why is important the traceability in clinical practice? This is perhaps a more delicate concept because traceability is necessary to have comparability. If there is traceability to results may be comparable, not in the opposite situation. But please note that comparability does not mean interchangeability. For example, in spite of 2 measurement procedures or measuring systems has the same traceability because are calibrated with the same reference materials, by reason of the problems with, differences between antibodies, for example, the results may be comparable but not interchangeable. Now I will present a practical example of calculation or estimation of measurement uncertainty in clinical laboratory. Always following the example of the catalytic concentration of alanine aminotransferase in plasma, the first thing is the description on the procedure or the measuring system that we are using. For example, one analyzer following, in this case, the procedure recommended by the International Federation of Clinical Chemistry. And we have, this is an example of a measured value. It is according to the VIM, this is not a measurement result. This is just a measured value. After the description of the measuring system, we must consider what are the different sources of uncertainty that can affect this measured value. In this case, among others, but this is the more important, maybe the pre-metrological variability, also pre-analytical, pre-examination, etc. The measurement uncertainty of the calibrator assigned value, and finally, generally the more important source of uncertainty is the day-to-day imprecision. The premetrological variability is a clear example of type B estimation. We must search the bibliography. There is no many bibliography about that, looking for some data of metrological variability. In this case, this data exists. We can find it in the bibliography, and we can use this data in this way. We have found a coefficient of variation corresponding to a premetrological variability, and this coefficient, this percentage, is applied to the measured value, and we can find the first component of the final uncertainty. The first component is due to the premetrological variability. The second one, the second factor of uncertainty is, in this case, and almost practically all the cases when we need a calibration, is the uncertainty of the calibration of the calibrator. This is also a type B uncertainty because the manufacturer has this information. If we need this information, the manufacturer is obliged, is a must for the manufacturer to give this information. This information is generally not given normally with the package insert, but we must ask especially for this information, and the manufacturer has always this information. In this case, is also we can find directly an information in form of standard deviation or in form of coefficient of variation, and we apply this value to our measured value. We have the second source of uncertainty. This is an example of the information given by the manufacturer about the uncertainty related to the assigned value. We made the calculations, and we have the second one. Finally, the most important usually is the day-to-day imprecision. This information is the information we have in our laboratory with the day-to-day internal quality control. Ideally, the control material should have commutability. It should be interchangeable with patient samples regarding precision. It is not always done, but ideally should be. And another consideration is the phenomenon of heteroscedasticity. The change of coefficient variance or coefficient of variation of a standard deviation that change with concentration. This is a problem that should be taken into account, and it is necessary usually to find in bibliography information, or if we are working with 2 or 3 control materials, different control materials, we can have this information, more or less precise information about that. Finally, we can apply this coefficient of variation due to day-to-day imprecision at our measured value. as these different standard deviations cannot be added directly. It should be elevated to the second potence and squared, and after that we can have the root square of this value to have the combined uncertainty. This combined uncertainty should be multiplied by a coverage factor. Usually this coverage factor is 2 to have the usual probability of 0.95 as in other cases. Finally, we are now in a situation, we have now a measurement result. The measured value 1,5 is now a real measurement result according to the VIM. And this is the take-home message. It's not difficult to calculate, of course, with a computer, of course. The information system of the lab can do that very easy. And with this information, a lot of people think that clinicians in general may be added, maybe helped with this information. And by the reason, I hope that after 10 or 20 years, all clinical laboratories will give measurement results and not only measured values.
Thank you, Dr. Fuentes. Next is Graham Jones, Associate Professor and a Clinical Pathologist at St. Vincent's Hospital in Sydney. He's active in professional activities, including Chair of the Australian Chemical Pathology Quality Assurance Program and a member of the JCTLM executive. He has interest in kidney disease, diabetes QC, and reporting of pathology results. I also think he's the longest or furthest traveling expert here at this meeting today, coming from Australia, and glad to see you're bright, fresh, and awake.
Thank you. First of all, I'd just like to express my thanks to Bio-Rad for bringing me this distance. Certainly, the meeting last year was professionally very, very exciting, and I'm certainly looking forward to and already enjoying this meeting. The previous presentation really set the scene, so thank you very much for doing that. It's about having a measurement value or a measurement result and communicating that to doctors. And the challenge there was that in 20 years we should all do it. What I'm going to say is going to be a bit negative, I'm afraid, for that proposition, but I'd prefer that we just see it as the challenge that we need to overcome. So I'll get underway and we'll see how we go. So what I'll talk about is what is the uncertainty of measurement. Does it include biological variation? Does it include pre-analytical variation, or is it just the analytical variation? How is it useful to clinicians? What are they going to do with it? How do we communicate this and then draw some conclusions? And I hope that people will later challenge those conclusions as is right and proper. And as we've just heard, what is it? And we can use the language of VIM, and I think it is important that we use the same language globally. It is very easy to misunderstand each other, and it's this beautifully termed non-negative parameter characterising dispersion of values being attributed to a measurand. I promise you I've never said that to a clinician, and I can probably say I promise you I never will. In practical terms, again, as we've just seen, that is a result, plus or minus an estimate, this non-negative parameter, which is the measurement uncertainty. Sorry, I'm going to stick to uncertainty of measurement. So not mu, and I'm doing that because it's the gum. So we're going to have not mu when in this talk. However, I think there are two concepts that we've got to deal with when we're talking about communicating our results with doctors. That's the uncertainty of the measurement. And in Australia, when our requirements under ISO 15189 to calculate that, to estimate that, it says very specifically it is the uncertainty of the calculation of the measurement that we perform in the laboratory. And that is one very important concept. The different concept is, and I've put it in this rather long-handed way, it's the uncertainty of our result as an estimate of the homeostatic set point for the analyte in a patient. What we're doing is trying to find out what their average creatinine is or their TSH is okay over time. And we're subsampling over time to try and get one estimate of what that is. And then we do one measurement with its own uncertainty. And I'll call that total uncertainty the uncertainty of the result, the UR as opposed to the UM. And we include in that the within-person biological variation, the pre-analytical and the analytical variations, and I won't go into maths of trying to combine any of those things here. So let's step sideways and say, why might we want to communicate the uncertainty of the measurement or the uncertainty of the result? And it really goes almost to, for us in laboratory medicine, an existential question. Why are we here? And our role is really quite simply to allow doctors to make better clinical decisions. With the exception perhaps of blood bank, where they deliver product, in pathology we're in the information game. And the better information we can provide, the better decisions that doctors make, and hopefully then the better outcomes for patients. The corollary of that to me is that in our world, if we talk about evidence-based laboratory medicine, our evidence base is, does changing our behaviour lead to better outcomes? And if we want to say that communicating results or uncertainty of the result, is that a good idea or not? That to me is a testable hypothesis. We say, are patients better when we do it? That's our highest standard in laboratory medicine. And as I've said, it's sort of why we're here. And it's obviously very important we're here because we all enjoy what we're doing. I'd just like to borrow this slide, and I'm saddened to hear that Per Hiltoft-Petersen is not able to join us, but this was the opening slide of a presentation he gave in Sydney, and I've quoted him many times because I think it's really fundamental to interpreting pathology results. All of our interpretation of a pathology result, a numerical pathology result, is by comparison with a population reference interval, with a clinical decision point, or with previous results on the same patient. And that particularly with Callum Fraser's work, is the critical difference, the reference change values. And those concepts will come up very briefly during the talk. You might have to concentrate to spot them as they come up. So, clinical decision making. I'm hoping that's not the way it is at the moment, but it was just such a lovely slide I couldn't help but put it in. So how does a doctor make a decision? And here's an example. Here's a poor sod of a junior doctor. He's got a patient who's come in with chest pain. How is he going to make his decision? First of all, he'll take a history. He might get 5, 10, 15, 20 items of information in that history. He then might examine the patient. In fact, we hope he examines the patient, and he'll get more information. He'll get a blood pressure, a heart rate, he'll do some palpation. Maybe if he lays his hands on the patient, he'll see whether they're alert or oriented or comatose. He'll get that information. He'll then do some tests, get the ECG, he'll maybe get a chest x-ray, he'll get a temperature and a few things, and then he'll get some pathology results. Might be a troponin, a gamma GT, who knows, he might get 30 pieces of information in there. So what he's got to do is filter all of that and apply some more weight to some things and less to others. He might be really interested in the nature of the pain, he might be really interested in the troponin, less perhaps in the gamma GT, the ECG is really vital. And he's filtering all that information. Then the question to me here is in the midst of all of that, communicating that I'll try that again, troponin may be up or down a little bit, is that really going to help it make his decision? And if it's far enough from the decision point, probably the answer is no. But if we're going to tell him also that the gamma GT, we're not really sure exactly what the result is, again, is that going to help him make a better decision? And that, I think, is the testable hypothesis. One of the things that came up in our working group last year was this concept of uncertainty of measurement. Does it come up anywhere else in medicine? And since last year, I've asked various specialists in our hospital anyway, do you have any reports that have an uncertainty on it? And I've certainly never seen blood pressure 160 over 20 plus or minus 0.5. I've never seen, the temperature's 38 plus or minus 0.2. The respiratory rate is always just 15 or 22. The ejection fraction is 45%. The valve width is 2.2 millimetres. The lesion size on imaging, the bone mineral density is whatever, nuchal translucency. So in my estimates of this year, I've been unable to find any routine uses of uncertainty of a numerical result anywhere in medicine, at least in Australia. And again, I'd be very interested to hear the experiences that other people have had in their own environments. So if we are going to communicate this uncertainty, we've got to think about how we might do that and do it in a way that we think is going to be helpful to doctors when they're looking after patients. And this is a slide from last year, which I presented at the end of our working group, and I'll go through some of these in some more detail. I've had a year to think about some of them. And I would certainly like to acknowledge everyone who participated last year, because I've shamelessly stolen their ideas and contributions. So let's talk about reporting uncertainties. Here we have a value, a measurement value, but not a measurement result. We typically report it. We're required by our accreditation to have the test name, the date and time, the result, the reference interval, the units, and we've there flagged that it's outside our population reference interval. As we've heard, we can typically report an uncertainty as the plus or minus X value, or possibly we might put a range of values because we know that doctors aren't very good at calculations, so we might put the range in to assist them with that. And I thought I was just going to write these down and then this would just be an example. But in fact, this raised a whole new issue when we start looking at this. What we've done there is say this result is outside the population reference interval, and perhaps you should take a bit more notice of it. But when I look at these results, are they outside the population reference interval? The uncertainty crosses that lower reference value. So what does that mean? Now, that will mean different things to different people. And at the moment, I don't know what it would mean to a clinician when they get that. So that question of interpretation is influenced by putting the uncertainty. Now that was the reference to a population reference interval. Let's go to a clinical decision point, a glucose of 7.1 millimoles per litre. Okay, it's only one of them, but if you have symptoms, that might be enough to give someone a lifelong diagnosis of diabetes. However, if we report the uncertainty of that result, so there we are, we've got symptoms, we've got lifelong diagnosis. We report an uncertainty. Uh-oh, does this person really have diabetes? Well, we're not sure. We better test again. We've changed the interpretation of that result because we've reported the uncertainty. And so now we're not quite sure. Now, each of these has some consequences which I think we need to think through before we start boldly firing out our uncertainties. If it's a reference interval and that uncertainty crosses the reference interval, what I would think that a thoughtful clinician would do would go, hey, that's somewhere near the upper limit. I don't mind whether I'm just in or just out, it's somewhere near that. That's a very reasonable thing to say. And frankly, whether it's just in or just out is not really our question. However, if we really want to apply the maths behind it, if the reference interval has been set using single measurements and we want to have 95% of our results outside, then we have to use single measurements to compare with that. Otherwise, we're actually doing something different. There's nothing wrong with doing something different, but we need to know what we're doing. The decision points, however, is different. A doctor might go, well, I want to be really sure my patient's got diabetes, so I'm not going to diagnose them till my uncertainty doesn't cross that limit. So they have to be 7.5. Whereas another doctor with the same information might go, well, I want to pick up all of them who might be diabetic. I'm going to choose the 6.7s and call them diabetic. What we've done is actually change the reference interval. We've changed the diagnostic criteria depending on that. So again, if we want to use a single reference interval, we have to have a standard response to it that we need to think through. So if we're going to report that uncertainty, that value itself, the choice of that single cut point, that clinical decision point, already includes some assessment of sensitivity specificity. We lay over that another bit of variability, and unless we've decided what we're going to do with it, we're creating some more uncertainty in the decision. So we need to standardise the approach, discuss, decide, and then make sure we educate. This is a screen scrape from our web-based computer system at St Vincent's in Sydney. We can have up to 9 columns of data on a single screen. The IT people did that for us a while ago, so you can see as much as you can. This is chosen at random. I just went in and chose a patient and actually chopped off a couple of columns so it'd fit. Now, how would this look if I put plus or minus onto it? It'd look like that. Now, I've doubled the number of figures on the page, and it gets a little bit hard to pick out what's going on. What if I wanted to do the X to Y? I have to shrink it to fit it on the page. We've now got 3 times the number of numbers on the page. And I put to you that what we've actually done in reporting that is increasing the complexity of what a doctor's got to look at. Their ability to pick out the things they want has gone up. Now, that's not to say it's the wrong thing to do, it's just to say there are costs to communicating this information. And that cost is included in real estate on our report. You have to buy bigger glasses if you're going to be able to read that. And finding the important stuff in the midst of that becomes harder. So it's not cost-free communicating all this thing in that format. So how else might we report it? Oh, sorry, this is another thing. Again, thank you, this was raised earlier. Hopefully we know what plus or minus something means, although I realised when I've got glucose 7.1 plus or minus 0.4, I haven't put down what the coverage factor there is. A lab person might think that's a CV, or they might think it's got a coverage factor of 2. I've got a range there. Now, if I was to ask anyone in this room, I know that you would say what that means is, that's a Gaussian distribution and most of them are within plus or minus half that range and 5% will be outside that. We know that's of course what that means. Is that what we think the clinicians think it means? They might actually think it's equally likely that a result is at the end or at the beginning and completely unlikely that it's outside. Unless their understanding of our plus or minus is the same as our understanding, we're not communicating what we think we are. And again, I would suggest that there's a need for some education in that process. If we're going to understand, we need to discuss and educate about that. One of the things that we discuss, and there's been a couple of publications out of Australia, is trying to communicate the uncertainty together with the value by the rounding of the digits. And every now and again, one of my clinicians, if it sneaks out of the lab, will say, "Ooh, you're very good at measuring HCG, aren't you?" To the nearest one place in 10,000. And it's obviously a nonsense. We might round it off to try and give a more realistic value. Some of my colleagues want to use roundings other than to deciles, so the nearest plus or minus 5 or plus or minus 20, because then you've got a more accurate uncertainty if someone knows what they're doing. So we might do that. Is that a good way of proceeding? Well, it's not bad, but it has effects. If you report, and this is just an example using HDL, cholesterol in Australia, some report to one decimal place, some report to 2. Our treatment target says greater than or equal to plus or minus 0.9. If you're reporting to 0.1, 0.8 you treat, 0.9 you don't. Decision point is 0.85. The same analyser in a different lab reporting to the nearest 0.1, 0.89, oh, don't treat, that's less than 0.9. 0.90, do treat. We've actually changed our treatment point by about half a millimole per litre. So even just the rounding that we're doing is having an effect on which patients we're even going to treat for their hyperlipidemia or hypo HDL treatment. So we change the decision point depending on that. It also has other effects, and this is a paper from that I've produced now a couple of years ago. It's my one foray into clinical chemistry, and I did look proudly to see there aren't many single author papers in clinical chemistry. And this is to show that the reporting interval size, the RAS, affects the calculation of the critical difference. As you have a bigger reporting interval, a bigger rounding value, you increase the critical difference by 1.5 times that. It's the mathematics. And if you look at that and go, well, that's a bit odd. But then if you think about it, if you like, the high school maths of that is that you calculate first and round after. And if we're putting out rounded data and then doing calculations based on that, we get less quality in the results. It came up at the session last year that we should do it graphically. This is a graphical result, again, from our system. You can plot any of the analyzers, again, chosen at random. It happens to be urea, and it happens to be going down. It's just randomly selected. And you can look at that. That's how it looks today. But I thought it could look nice if we put some uncertainties on that. And we could go, that would then highlight that, oh, that change from the third one there to the fourth, that looks like a big change. It's within the reference interval, and it's significant, but it's real. Whereas that change where it just crosses the lower limit and scores an asterisk may not be so real. And we could put more things on that, like an asterisk to say where the probability exceeded it. And I think this is quite a nice concept to try and give the information without being too didactic. As an example, though, this is calculated using, I think, a biological variation of 14% for urea. If I just did, that's result uncertainty of the total result. If I just did uncertainty of measurement and did the same graph, I'd get this. It looks like every result is different from the one before or after because it's leaving out the biological variation. So I think measurement uncertainty for clinical interpretation is potentially dangerous. So uncertainty of measurement can be misinterpreted. How else can we report uncertainties? We can do it as a comment. And this is one we've got in our lab. The emergency department insisted when we brought in high sensitivity troponin that we do the calculation for them. Took a while to program, but if the change of troponin is more than 30% in a certain time frame, we put a comment down there where we do the calculation for them and indicate that that could be consistent with an acute myocardial infarction. We're communicating the value. This is what it actually looks like in our environment. Another way we could do it, you see down the left-hand side, all those test names are in blue and underlined. They're hyperlinks, and we can hyperlink to a page. And this is an example showing that for albumin, we've given the precision of the assay, we're given the within-subject biological variation, we're giving the total resultant variability. Someone can go and look for it if they want. That would be another way of providing the information. Again, with thanks to Callum Fraser, this is probably, I think, the best example of putting it into a routine use with the various symbols there. The chevrons indicating it's outside the reference interval, either by a little bit or a lot, and the asterisks meaning it's different at the 95% or the 99% confidence limits. And I emailed Callum and said, how did this all work? And how did you support it? And I'm now paraphrasing, so you get right of reply later. That he had very few questions in response to the chevrons, stars and double stars. The clinicians didn't really say what's going on. It just went straight through. They did, however, work really very hard at trying to communicate what it means with bulletins, with regular information in the handbook, the training of the junior medical staff who I gather stay where they are in Scotland, so that Callum had taught a lot of them as they went through, and the duty biochemist took an opportunity to comment. So what he'd done was support that concept with a lot of education to try and make it all work. This was a poster that I presented in Australia a few years ago. The critical difference theory is usually based on one measurement before and one measurement after. Now we know that the maths changes if you've got several measurements before you start someone on a therapy or on several measurements after. And this is just an Excel calculator where you can put in the values before, the values after if you've got more than one. And this one's creatinine, and it's gone from an average of 103 to an average of 120. And the probability of that being real is 98%. So it's provided that information. And that was presented as a poster a couple of years ago. So that's another way that we can provide. We can provide calculators so that people can do it. I've been a bit rude to our clinical colleagues here. I've suggested they don't understand what's going on here, and that we might be overestimating their ability to handle this. But in fact, doctors have an incredible knowledge of this. They do it every day. Every day we put 4 million results out every year, and they look at it and they decide, oh, that's important or that's not important. They make that decision day after day. They don't respond to small changes. They do respond to big ones. And I guess the area is in the middle-sized ones. Are they responding correctly to that? One of the things we did at St Vincent's, I was having a medical grand rounds and handed out these responders like you've got, and gave a whole series of scenarios and said, if this was one where if the sodium was 140, how far would it have to change for you to think it was clinically important? And they all pressed their things, and the different colours are different types of doctors and people. And most of them thought about 135 would be a real change. Some thought 139 was a real change, some thought 132. What does the theory tell us? 139. 135. They were spot on. They weren't spot on for everything else, but the idea that they don't know about this is not true. They know a lot, they can't put the maths to it, but they have some understanding. As I put to them later, that in a test they're not familiar with, their understanding is a lot less. So, just to try and summarise, if we're reporting uncertainty of our result, the advantages are we're hoping for improved clinical decision making, that they will recognise true changes, they will avoid responding to insignificant changes. And as we heard previously, it might indicate that a point of care method is not as good as the lab method if the uncertainty around that is a lot bigger. And it can highlight that the imprecision of results at a very low TSH is quite different to the ones up in the reference interval. The disadvantages, and as you can see, the list to me is a bit longer at the moment. It can be confusion. What does it mean? It can be confusion. The reports get more complex. The reports, if they were different from different places, if somebody else used different signals in a hospital down the road, that would be very difficult. Real estate on our reports is hard. It might be misleading. Have we taken everything into account? Have we allowed for that little bit of hemolysis? Medico-legal. You told me that difference wasn't important, and I didn't act on it. Whose responsibility is that? Confidence in the lab. I have a colleague who did this in New Zealand about 28 years ago, and he said they had to switch it off very early because the doctor said, I'm going to use the lab down the road. They're not uncertain about their results. And also that we have this huge educational burden that at the moment the concept of uncertainty in looking at numerical results is not usual. So reporting uncertainty. I think we should do it, but only after consultation and agreement and education. I think similar practices, doing it the same way in a city, an area, or a country, a world, would be ideal. The criteria is that it improves patient outcome, and to me that's a testable hypothesis. So we should research. Does it actually help patients get better if we report uncertainty? And I think probably starting in some areas like are changes in tumour markers, are changes in serum creatinine, are they important? And should we focus on ones where we think it's likely to be important and sneak up on the clinicians so they can't see us coming? And with that, I'll just thank you for your attention. Thank you.
Great, thank you, Dr. Jones. It's really exciting for me to see the kind of the continuation and evolution of the work that we've had from the working groups. In particular, I know that this subject has been one that we've had. It's sort of been gnawing at us for past few years. We've struggled with getting some common understanding around it, and it's nice to see sort of the work group, at least, the outcome of that, and that it's continuing in your work that you're doing every day. So that's exciting to see. We do have a few questions. Beer? No. Okay. Question is, this is for you in your practice. How do you educate clinicians about result uncertainty? Okay. So we've got a mix of people doing talking with clinicians individually or making a mix, and we've got a group that isn't doing anything at the moment. And I think that fits with what the experience has been so far. This is sort of new concepts about how do we work with clinicians. There have been different suggested approaches about doing uncertainty of measurement, and we'll talk about that some more. This is an opinion question. This is just your opinion. Providing data about uncertainty would, and pick the best that fits for you. Interesting. Probably improve, but also create more confusion than it's worth. I think, and what we've seen from the presentations is as this sort of evolves and there's new ways and new techniques to how to convey the information and to educate and provide that, we might see this change.
Max, if I can comment, it might have been nice to ask that question before my presentation.
Right.
But also, I have been perhaps deliberately provocative. It's not necessarily that I fully believe everything that I've said. So just to put some possibilities out there.
Right. And we may, just for the rest of the day and tomorrow, we may front load, do the questions before the presentations, just if that, it might give you a different way of doing it, because I think you've seen some of the answers. So this is in practice, for assays that have known biases to other tests, e.g. troponin and some tumor markers, I Okay. Great. So again, there's other techniques about communicating information. This is about, I think this also goes to the laboratory having a very prominent and important role in the entire patient care continuum, and being able to sort of help clinicians and help the other decision makers understand what we're doing. I think that one last is how useful opinion is metrological traceability for medical practice. Just the best answer that fits for you right now. And we range from very useful to could be useful. And again, I think it's sort of evolving in how we think about traceability. So just one comment. In the latest ISO 15189 revision, there's a current draft that's due to be published later this year. So the working group 1 of the, a lot of terminology, but ISO Technical Committee 212, which was convened in Las Vegas in last October. A lot of discussion about uncertainty of measurement and the requirement to report uncertainty when available to clinicians and report it with the test result. So I'd be interested if somebody, well, let me tell you this. There was a lot of discussion about it, and there was discussion that needed to be a little bit more guidance about what that means, and to allow laboratories to be able to work with that. Because what we've found, or what we've heard, is that right now we have, 57% in this group say they're accredited to 15189, and I would bet each of you does something different about uncertainty of measurement. And I would bet some of you may not do anything about that, and maybe the accreditor or assessor let that pass because whatever it wasn't available, or you hadn't done that yet. So there's a lot of talk about how to provide more guidance to laboratories in doing that, and to make it sort of a little bit of an easier process, a more straightforward process, and something that's usable. Does anybody have an experience about their ISO 15189 accreditation and how they've addressed uncertainty that's been something that you're proud of or has worked for you very well? Is anybody here, maybe show of hands, we can't really re-poll or poll it right now, but a show of hands of people who are involved in the rounds of their hospital. So as a part of the laboratory team, you become a part of sort of the care team and doing rounds in the hospital and consulting with clinicians. Niels? So it's certainly been, it's a model that has been tried in various places, and it's been, people that have done that, I mean, we can ask our colleagues here, have reported that it's been really good for helping to educate the clinicians about sort of the limitations of tests and what it means and how they're seeing their patients. So, Niels, did you have a comment on that?
Well, thank you for the excellent presentation. I think the most difficult part in the uncertainty of measurement reporting is the coverage factor. You can have a discussion about whether to take into account biological variation or analytical variation, but the coverage factor is varying very, very much because it's dependent, in my view, on the level of suspicion the clinician has. And it may rise from 0.1 till maybe 1,000, so that makes it very difficult to report it in general, but makes it very, very valuable to talk or to discuss about uncertainty in individual patient cases. It makes a lot of difference whether CEA was measured, before anything else is known in a patient, but there is some level of suspicion about maybe colorectal cancer. Or the other case when it's measured in a proven case of colorectal cancer after treatment. And your coverage factor is completely different before and after. And you have to take that into account, and the range of the coverage factor is enormous in my view.
Thank you. Comment here.
There's one other area of uncertainty that neither of you really touched, that you raised in one of the questions you raised at the end, and that is the variation between laboratories. In the part of England that I work in, I act in a regional centre, and patients are either bled in our hospital or in the other hospitals in the surrounding hospitals. Some of the cancer patients will have a creatinine done in one hospital, which would mean they shouldn't have their chemotherapy, and they go to another hospital, and they do have their chemotherapy. And that is something that we don't look at, and it is not measured by any of our control systems.
Is there more? In the back?
Rob Jansen, the Netherlands. I would like to comment on that. I think it can be measured, and that can be measured by the external quality assessment, unless you have commutable samples, unless you have biological variability included in the tolerance limits, and unless you have the clinical range covered in that scheme. We do have that. And as a matter of fact, we have a pilot last year, started in the BIRAT conference here. We set up a pilot with Portugal, Spain, and the UK, and I'm analyzing now the results. And it's very interesting to see how large laboratories results differ. And I can show how small the difference can be if you practice this during years. So it is possible, however, difficult to do.
Okay. Thanks, Rob.
If I could just make a comment on that, the earlier slide I think we saw showing the pre-analytical and post-analytical being the dominant area of errors. It has the potential to take our focus away from what we're doing. No one will care about what's happening in the lab except for us. So having the commutable EQA programs, looking at the bias, having traceable things so that we can have the companies can deliver it, we absolutely need to take it, and it makes a big difference. People do or don't get treatment. People do it. I had a discussion with a GP recently, and she had this touchingly naive faith that if the methods were different, our reference intervals would allow for that. And she looked at me very strangely and I said, no, they don't do that. They really believe that we know what we're doing and that we're giving results that really mean what they say they do, and it's up to us to find it. And we can't. The idea that everything that's happening in the lab is right is still a long way from being true, and we need to make sure we're aware of that.
Great. Cal? Andy, up here. Forward. Second row. On this side.
Thank you. I actually think that one of the major problems is the changes in medical education that have happened over the last 20 to 30 years, and that the best opportunity to get across the concepts of measurement error, uncertainty, reference intervals, what is a significant change in laboratory results and so on, is using case studies with undergraduates. And if we could go back, I probably can't, but if we can persuade our universities to incorporate more and more teaching of that sort, I think that would be a better move than trying to educate some of our older practicing clinicians.
Great. Well, thank you. This was a lively discussion, a great discussion, and we're now ready for a coffee tea break. We'll check the time. We've got 30 minutes afforded to us. I suggest we keep it to 20, and if that is okay, and we'll stay on time. So if we come back at 25, 11:10. Okay, so we're back at